So this patient had a cholecystectomy 2 years back. The gallbladder was stuck, so they could not remove the gallbladder completely. They did a partial cholecystectomy. She came to us about 6 months back with a CBD stone. We removed the stone and placed a stent. Um, Now she comes back again with complaints of pain. On CT scan, the stent is not there, it has migrated, and there is possibility of another CBD stone as the CBD is dilated. So we will start as we started before. So I will show you. See, this is the tongue. We go to that hyperechoic line, millimeter by millimeter. See this? As we go there, I go down into the and follow the air. So this way it goes easily and you don't get stuck anywhere. Keep sucking and you reach the arytenoid. You also see the thyroid here. See this? This is the thyroid. Thyroid seems to be having a cyst here. See this? There is a cyst in the thyroid here. So anyway, so that is, and then gently try to go into the cricopharynx. We are in the cricopharynx now. Turn anti-clockwise, please. And you see both the aorta and the pulmonary artery. So we are seeing the aorta and pulmonary artery here. See, this is the aorta. Come back. Yeah. Here. See this? That's a pulmonary artery. You can beautifully see the full left pulmonary artery. This is the arch of aorta. So you can see any lymph node that is there in this area very easily. Then turn little clockwise. Look at the head eye karo. Look at the trachea. See the esophageal wall. You can see the esophageal wall beautifully. Bada karo. And this is the G junction. And we are in the stomach now. So see, freeze. This is the diaphragm here. And this is the G junction here. You can clearly visualize all the wall layers here of the G junction, just like a sagittal view on CT. Actually, I feel it is even better than CT. Once you have done this, as I showed you last time, we look at the fundus. There is some water here, gastric juice. We try to suck it out. Go to the tip. So this is, I am doing anti-clockwise. Then I turn clockwise. This is the left hepatic vein. See there? Please. This is the left hepatic vein. So segment 2 and segment 3, like I told you last time, turn clockwise, ligamentum teres, left portal vein, come back a little and then turn clockwise, freeze. So here is the CBD. Let's measure it. .3, mildly dilated. So you have portal vein, bile duct. I am tracing them millimeter by millimeter, going towards the pancreas. You see the duodenum there. We go in and trace. This is the head of the pancreas. SMA, SMV. See this? This is the SMV and SMA. And underneath the SMV is the head of the pancreas. You can nicely see the head. There seems to be no mass here. Now here we should see the bile duct. Please. So this is the bile duct. Here we have not seen a stone from the stomach as yet, but let us see again. So you see the bile duct, it's coming here and to the SMA. I don't see a stone unfortunately, so we'll have to go to the duodenum to confirm what is happening there. So the head of the pancreas can be visualized well. Now, once you have seen the head completely and visualized it nicely, then you come back, look at the pancreatic duct and keep it a little anti-clockwise so that you see the pancreatic duct. See, this is the neck area. Then I turn clockwise and you see this cyst. So there is a cyst in the pancreas. What is this? This is a large cyst. Please. It looks like a clear cyst. It's about 2.5 centimeters. Let us try to understand what is happening here. Doppler. So you see the pancreatic duct is just below that. There, freeze. And it looks dilated. 3.5. So it is mildly dilated. Looks wise, it looks like a serous cyst, but we don't know. See there, the pancreatic duct is dilated beyond. Turn clockwise again. Look at the rest of the pancreas. Turn clockwise. So I am looking for any changes of pancreatitis here. This is the tail. You see that? This is the tail of the pancreas. I don't see any calcifications. I will not say that this is chronic pancreatitis. Looks there are some dots and strands, but nothing more. Let's go all the way toward the spleen and see what happens. This is the spleen. So dots and strands. There is a cyst, and then now whether we should aspirate this or not, this is probably a serous cystic neoplasm. The other possibility is a pseudocyst. So I think it's better that we quickly aspirate it. We use a 22 gauge needle and do an antibiotic prophylaxis before we aspirate the cyst. So the possibilities that come to our mind is a pseudocyst, serous cystic neoplasm, or a side branch IPMA. I don't see it communicating, but on EUS it is very difficult to say. So we will quickly aspirate it. We use a 22 gauge aspiration needle, not to use a biopsy needle here, and give an antibiotic. So Dr. Dharudkar is giving the antibiotic dose. Check that your needle is out. Get into good position. So I'm withdrawing my scope little and then checking the needle where it is coming out. If you see on the top, you will see the needle there. See that? There. So I'm not able to get in. Now I'm in. Aspirate. Anything is coming? So now we are getting, it's a serous fluid, doesn't look like a pseudocyst. It's a very clear watery fluid if you can see it on the camera. We try to aspirate it as much as we can. So looks wise it looks like it's a small serous cystic neoplasm. Try to empty it completely. So in about 4 or 5 cc's this is completely emptied. We close it, withdraw the needle, and we normally send it for CEA, amylase, glucose, and cytology. So you see here now, this is the dilated pancreatic duct. So that is the only thing I don't like about it. If you call it a serous cystic neoplasm and then the pancreatic duct is dilated beyond, is not a nice thing to have. So better we aspirate and find out what is going on here. You see the head of the pancreas very beautifully seen now. So I'll just show you. This is the superior mesenteric vein. This is the head of the pancreas. Nice echo texture. This is the neck region, pancreatic duct here. So you can look at the head beautifully from the stomach. The only patient where you will not find a good evaluation of head is patients who have chronic pancreatitis and patients who are very obese, in which cases sometimes, see like this beautifully you can see the entire head like that. See that? Underneath you can see the IVC. So this Doppler, I'm just trying to see if I can see the stone in the bile duct. बंद करो. Yes, I can see. Can you see it? Please. So this is the stone in the bile duct here. There is a shadow underneath it. So there is a stone in the bile duct. It's in the retropancreatic portion of the bile duct. I will try to focus it more. See that? There. It's a large stone. So from the we found that there is a CBD stone. Now let us quickly go to the duodenum endoscope. We will go to the duodenum and see, confirm our findings, what we have seen. So all this evaluation that I did from the proximal 5 centimeters beyond the GE junction. Now we will go to the duodenum. हवा नहीं है यार बिल्कुल भी. है ही नहीं हवा. हवा है ही नहीं. Zero हवा है. So there seems to be some problem here with the air. करो ना. करो ना. हाँ पानी आ रहा है. Now this looks like little okay. So we go in. Still the air is not sufficient. Something is blocking the scope, which happens sometimes. So we'll go in to the duodenum. I am in the duodenum now. And the moment you go to the duodenum, you turn either clockwise or anti-clockwise, right? So let's turn clockwise towards the papilla. There you see Doppler. This is the portal vein. then some collaterals. There is the stone. You see the stone? Large stone there. Band karo. But is this stone in the bile duct or it is in the remnant of the gallbladder? As I told you, this is the bile duct. See this? Here the lower bile duct looks quite okay to me. I am turning anti-clockwise now and I see this big stone. Then let us look at the gallbladder area. See, this is the gallbladder area with multiple stones. So it is possible that we are dealing with a slight case of mirisis. So this case will definitely need an ERCP. So here you are seeing the head of the pancreas, the bile duct, and then the portal vein here. See this? There are some collaterals here. This is the neck freeze. So here you have the neck of the pancreas. This is the cyst we aspirated. This is the pancreatic duct here. There doesn't appear to be any communication here. We'll quickly do the D2 and see endoscope. So the D2 is exactly like how you do for ERCP. Be very careful when you are going from D1 to D2, especially for the beginners, because you can perforate it. So do it under vision as far as possible, and if it is not possible, don't push yourself. So this is the D2. We shorten just like ERCP, turn anti-clockwise, and here you see the spine, please. This is the spine and the aorta, please. Come back, come back, come back, and withdraw. And now I start doing up and clockwise. And that should bring the pancreas in view. I am doing extreme clockwise now. See, this is the extreme clockwise, and you see the mesenteric vessels. So this is the uncinate process. See this? This is the SMA and SMB. Look here if there is any lesion. Doesn't look like the pancreas ecotexture is fine. I am withdrawing millimeter by millimeter, doing clockwise, anti-clockwise to see if I am seeing any duct. So far, nothing. Sometimes the scope falls. You shouldn't worry about that. You can go in again. We don't use balloon normally. So see, you can see the whole pancreas here. I think I am seeing a pancreatic duct here. Yeah. So here is a duct. This is a pancreatic duct. And then if I turn, see, this is a pancreatic duct. See that? This is a pancreatic duct. And then I turn a little more anti-clockwise to see if I see the bile duct. That's the bile duct. See that? Patient is coughing a bit. That's okay. As long as Dr. Dharudkar is here, I don't bother. See, this is the bile duct. We are seeing the retropancreatic bile duct. Looks okay. I withdraw gently. Keep looking at the bile duct. See this? This is the bile duct. Above the pancreas now. Now you see some sludge, and there is the stone. See that? Please. So this is the stone here. Now, frankly, I don't know whether this is in the bile duct or whether it's a Mirizi kind of situation. Let's try to see if we can find out. Large, very large stone. Turning anti-clockwise. No, it's in the bile duct. See there? You can see the cystic duct separate. Freeze. So this is the cystic duct here, which is not dilated. This is the bile duct. So it's in the bile duct, the stone here. See that? It's at the junction of CBD and cystic duct, but on EUS I feel it's in the bile duct. We will see when we do the ERCP. So this is how you evaluate the pancreatico-biliary system from the duodenum. Pretty straightforward. Um, I think that's about all that I need to show about anatomy. So this is the CHD freeze. You can see this is the liver. This is a CHD. It's obviously dilated, and you can see the bile duct entering the liver, the right and left. See here. So this is the hilar area here. Okay, that's it.